So good morning, good afternoon. Good morning. So as Nelly mentioned, I'm going to be talking about simulation and system errors and how to identify them. I have no disclosures. So we're going to be learning about how to review the definition of a system error, how to recognize the benefits of simulation, understand how simulation can actually identify system errors, and acquire knowledge to systematically address system errors. So definitions, so there's error, there's system error, and there's adverse events and sentinel events. So an error is any failure of a planned action to be completed as intended, or the use of a wrong plan to achieve an aim. System error is a failure in the way that resources are provided to the delivery system as a result of the organisation of healthcare. And in that definition, the key word is organisation. So it's the organisational structure which affects and can cause system errors. An adverse event is any injury caused by medical management that is not related to the underlying disease of the patient or the condition of the patient. And these can be minor adverse events or major adverse events. A major adverse event would lead to a sentinel event, which is either death of a patient, permanent injury, or minor injury but significant. Other preventable adverse events can be classified as near misses, which we'll talk a little bit about. So this slide is a little bit busy, and I don't expect you to be able to read all the fine print, but it's just to emphasize the importance of having a system of categorization and using a common language so we all understand what we're all talking about between institutions, between different groups of specialties. So errors can be caused by systems or human errors. So human errors is a whole different lecture in itself, which we don't have time to discuss today. But in terms of system errors, these are either organizational or technical. And further down the line, these can be divided into different categories, such as, like I mentioned before, defects in the actual organization that we work in, defects in leadership and management, which can lead to system errors, and not following protocols and peer-reviewed guidelines, things like that can lead to system errors, and also lack of knowledge, lack of how to tackle certain situations can lead to system errors. So the Swiss cheese model. So this, hopefully you've all seen this type of image before, and it's a way of depicting latent errors and active errors. So a latent error is due to a workplace or system error from the organization. And these can be time pressures, reduced staffing, inadequate equipment, or poor protocols. Active errors are such things as human errors, and these directly affect patients through direct patient care. So in terms of the Swiss cheese model, so there can be lots of potential hazards in our workplace that we don't always recognize or know about unless they lead to some catastrophic event. So if a minor hazard occurs, there should be roadblocks in the way to stop that progressing and escalating to cause patient or even staff harm. Now, if all the holes in the Swiss cheese model are lined up and there's no roadblocks, the small error can escalate and turn into a major error and then affect patient care or even staff health and care. So active errors, such as mistakes as in related to human error, if we have a latent error such as time pressure or reduced staffing, this can lead to a human error, such as people making mistakes because they're trying to hurry up, they're trying to skip corners, they're using poor judgment in the heat of the moment. So they are interlinked. So our role in simulation and all our roles in healthcare are to try and identify system errors to stop them escalating and causing further harm. So in 1999, there was a landmark report published, and I'm sure you've all heard of it, published by the Institute of Medicine, To Err is Human. So this report mentioned that there was between 44,000 and 98,000 US preventable deaths from 1999. And this was really unacceptable, to think that you go into hospital as a patient and you actually have harm sustained to you. So people wanted to try and think of ways to reduce the incidence of preventable medical harm, and they adopted a 4-tiered approach. And the 4 main aspects of the report were to create leadership. If you have good leadership, it can affect the whole institution, it can affect the whole division, department, team you work in, and it gives people enthusiasm to try and improve things. So the AHRQ, which Neola does some research for, was established, and that one of their main focuses is to prevent medical harm. They also mentioned to develop a nationwide public mandatory reporting system when there's a patient death or permanent injury or harm. And they also recommended having voluntary institutional-wide reporting systems to report near misses or minor injuries to patients. And they suggested to have standards of care, and not just to have standards of care, but to actually implement them and have accountability if they weren't adhered to. And to enforce a culture of safety by having safety systems in place. So every time we go to work, we should always be thinking about how to progress and enhance our culture of safety to prevent patient harm, but also harm to staff. Staff members can be harmed also from system errors. So in terms of a medical error, it doesn't only harm the patient, it can harm the family, like I've mentioned, it can harm the staff member, like I mentioned. It can also be detrimental to the family. So families lose trust in the healthcare system. They become dissatisfied. Patients, if they haven't been killed, they're left with permanent injury, psychological impairment. In terms of staff then have poor morale, have frustration in the workplace, which leads to poor team player aspects. And also in society, it can have a knock-on effect in terms of people not being able to work, children being off school, a low health status in our population. So just one patient injury can be catastrophic to quite a lot of different communities. So causes of death in the US in 2013, from all causes there were just over 2.5 million. And medical errors accounted for 1/10 of these patients, just over 250,000, which was the 3rd leading cause after heart disease and cancer. So in 2013, there was 35 million hospital admissions. So taking these medical errors into account, it means the mortality rate from a medical error is 0.7% of all hospital admissions, which is a staggering number if you think about it. Even one medical error is one too many. Now this is just the average number, just over 250,000. And it's difficult to get very accurate and precise data because on death certificates, we don't write down medical error. So there is some movement trying to add a box on death records, death certificates, to allow it to say it was due to a medical error. Not to cause blame to people, but just to get more accurate data. So Neola mentioned lots of organizations already, and here's the same ones and a few more. So all these organizations, the patient safety education is throughout all these organizations, and they each tackle sometimes the same issues, sometimes slightly different issues. But the main goal is just to reduce harm and hopefully one day have zero number of patients being harmed. So our society here, so we have a patient safety committee, which I'm a member of, and we meet twice a year to try and establish guidelines and do talks and write papers and things to try and educate people on patient safety. I just want to highlight one organization called the Patient Safety Movement, which is a new organization based out of Irvine in Southern California. And I went to their conference in London 2 weeks ago. So the annual conference is usually in California, but it happened to be in London, so I thought I'd make a trip and go to London. And this was started from the CEO of Massimo, the company that makes non-invasive hemoglobin monitors. And he was staggered. It's a guy called Joe Kiani, and he was staggered by the "To Err is Human" report. And also in 2010, Medicare published a report and documented over 180,000 preventable deaths of their patients. So he's not a nurse or a doctor or a healthcare provider, he's in medical technology. But he was alarmed by this number of people who were harmed. And he wanted to start tracking these patients, tracking why this was happening and who was being accountable for these patient deaths and also significant patient harm. Which I find quite interesting because you'd think it'd be someone who's actually on the forefront of patient care who would be doing that, but he was just some observer in medical technology, but he took it under his wing to try and reduce preventable deaths. And his campaign is to have 0 preventable deaths by 2020. So at this conference, there was quite major people there. President Clinton gave a talk, the General Director of the World Health Organization gave a talk, the Chief Medical Officer from the UK gave a talk, the Department of Health Minister from the UK gave a talk, and the whole emphasis was on reducing patient harm and increasing patient safety. And also there was patient advocates there. There was some mums who'd lost infants to one of the patient's child had an NG tube put into his lungs rather than his stomach and was fed and died. And now she's a patient advocate to try and educate people on correct placement of NG tubes, for example. So how to recognize the benefits of simulation in terms of trying to prevent medical errors. So the benefits of simulation, which Naola mentioned already, some of these. So non-clinical skills are a major part of learning from simulation. And having non-clinical skills such as good collaboration between different disciplines, having clear leadership, having very clear and precise communication, and also debriefing. All these non-clinical skills can then help us in our clinical workplace, in our clinical practice, and hopefully work together better as a team and ultimately improve patient outcome and decrease patient harm. Naola also mentioned, showed this picture, which I think you can never see too many times. And I was going through all the different aspects and key points, and I was thinking which ones should I mention as being the most important? And I couldn't really find one that was the most important because they're all important. So there's 11 key points, and all these key points, if we take them into our workplace and use them every single day, working as a team, we can improve the care that we give to patients. So in terms of preventability, so the idea is to try and identify things in our workplace that is potentially going to cause patient harm and to prevent it before it actually does cause patient harm. So this was a study published in 2014 from New Zealand, which looked at pregnant women who had been admitted to the ICU or HDU over an 11-month period in 2011 to 2012. And the yellow box is provider factors that caused a preventable harm to the patient, or not preventable, but improvement in care was needed. And the red box highlights the system factors. So they had 39% of their patients had preventable harm, and 37% had not preventable, but improvement in care was needed. So from the provider factors, the most important or leading factors were poor diagnosis and recognition of high-risk patients. So it's really important that we are very diligent and try and identify early patients who are at risk of significant morbidity and mortality, and also not to delay treatment and to give the right treatment. Now, both of these things can be influenced by good communication and following good and accurate and up-to-date, evidence-based policies and procedures. Now, communication is a major thing in terms of adverse events happening to patients and to staff. And the majority of root cause analysis of significant morbidity and mortality cases list communication as one of the top causes of harm. And the CMACE report from the Confidential Inquiry report from the UK mentions that they identified 50% of the patients who died had preventable issues. And there's also papers published in the US about maternal mortality that also document communication as a leading factor that contributed to the patient's death. So understand how simulation can identify system errors. So Naila mentioned a little bit about different places we can do simulation in a high-tech simulation center or on labour and delivery, or as you saw in the patient's waiting room. So I just want to mention a few things along the same lines that Naila mentioned in terms of the pros and cons. So we've been doing simulation at Stanford, obstetric simulation, since 2005, and Steve Lippman, one of our colleagues who's just left Stanford, started it, and then myself and Naila joined later on. And they started off doing simulation in this simulation center, and then some drills in labour and delivery. And we used to alternate between the simulation center for 6 months, and then do 6 months in labour and delivery. And after every simulation, we do a survey of the participants. So our participants are multidisciplinary. It's anesthesiologists, obstetricians, nurses, technicians, medical students, and we always survey them, and they would rather have the simulation in labour and delivery because that's where they feel more familiar. So now we do all our simulations in situ on labour and delivery. So the staff find it more familiar in terms of location. They know where equipment is, they know how things work, and also a big element of simulation is psychological fidelity. So we want participants to get in the moment and to think of it as actual real patient in a real situation. So the more you can make people relax and feel like they're in their normal working environment, it can help the way they adapt to the situation, to the simulation scenario. It's also cheaper to be in the labour and delivery rather than the simulation centre, and we can, in theory, do drills day, during the evening, during night shift. And one of the key things that we do at Stanford is after every single simulation drill, we write down all the system errors, however major or minor they have been, on a bit of paper, and they're all collated. And every single system issue that's been established is dealt with, which I'll talk about in a few minutes. During the process of doing in situ drills, you can test new processes, which you can't always do in a simulation center. And we can learn new things about our organization, how things are set up. So the cons are that it's low fidelity. So we're not using we do have a life-size mannequin that we use in labour and delivery, but it's a mobile one. It's not set up in terms of the high-fidelity ones that are in the simulation center. But low fidelity is still a very good method to learn. And you can do it anywhere. We've done simulation drills here at Shnider a few years ago. We've done them at SOAP, the annual meeting in May a few years ago. And you can do them anywhere. Ed Riley and I volunteer with an organization called Kybeli, which is an association linked to SOAP. And we go around the world and educate providers about OB anesthesia. And so a few years ago, I went to Armenia, and I took a life-size mannequin with me. Now, it wouldn't fit in my suitcase, obviously, because it's a massive mannequin. So I borrowed Brendan's bike box, which any of you know is quite a big box, and you could fit, a life-sized person in the bike box. Anyway, so I go to Armenia, do the simulation, and we just have it just in the conference, in the back hall, like on a table, like we have tables outside now. We would just do it on the table, not in a fancy simulation center. And our participants got a lot out of it. I I mean, to them, they don't really do a lot of simulation because they don't have the resources to have mannequins and things, but just going through communication skills, aspects of non-verbal communication, closed-loop communication, they found it very valuable. The funny part of the story is that when I was travelling back, I went via the UK and then back to the US, and I was in Manchester Airport waiting for my luggage to come back. And I thought this big bike box would go to the oversized luggage place, not on the conveyor belt. Anyway, it came out on the conveyor belt, and the bike box, it's not a sealed box. You can put your hand inside it, if anyone knows what I'm talking about. Anyway, part of the mannequin's hair was sticking out the bike box. So there's this life-sized, bag going around on the conveyor belt with the hair sticking out, and I'm thinking, well, I'm going to get pulled over in a minute and ask some very detailed questions, but I just picked it up and walked off, and that was it. Anyway, the moral of the story is you can do simulation anywhere, in a hotel, in the parking lot, anywhere. So when we do simulation in situ, there can be disruption to the unit, but we try and work around that, like Neil mentioned. And there is potential to compromise patient safety in terms of when you're using syringes we use air-filled syringes that are labelled, and there is potential for those to be mixed up with in-patient care. So it's really important that we keep our equipment labelled for simulation use only. So in terms of clinical system errors so I mentioned at the end of each drill, we write a list of all the system errors that have been identified. So here's a list of some clinical system errors that we've identified. So Neil mentioned about transportation of patients to the OR. So we used to transfer them onto a gurney from the labour bed, then onto the operating room table. But we found that was taking too long. So now we just transfer them on their labour bed straight to the OR, onto the OR table. We found that it was also taking too long to get the patients out of the room because the IV was still attached, and trying to push the patient out of the room with the IV pole, it all getting pulled, the patient's hand getting pulled with the IV and stuff like that. So now we disconnect all IV fluids, the magnesium, magnesium, Pitocin, so the patient's not attached to any infusions. The first thing we do when we get to the OR, after the patient's been transferred onto the OR table, is to reattach the IV fluids. But just that simple disconnection of IV fluids sped up the transportation of the patient. We found that nurses wanted to become more familiar with the MTG and to know actually for the runner to actually where for them to go to get to blood bank, the most quickest and direct route. We found that sometimes during the simulation drill it wasn't possible to get quick access to lab draws, so now we have more accessible tubes for blood samples and things. And one of the major things that we are proud of is the identification of a postpartum hemorrhage kit. So we used to have all the different medications stored individually, and I'll show you a video on the next slide. And it was taking too long to take out the individual medications, especially when you've got a woman who's having a major OB hemorrhage. We all know how fast the patients can bleed. And now having all the medication in one kit, we just take everything out at the same time, and it saves a huge amount of time. So also we found that we didn't have easily accessible Ambu bags. So now we have an Ambu bag in every single labour room, in the hallway, in every single OR, in the PACU. We found that during some of the simulation drills, the nurses would bring some forceps to the obstetrician, but it was the wrong types of forceps because they weren't labelled. So just little things like that can speed up time, can decrease the need to re-sterilise something that's not even been used. We found that we didn't have easy access to betadine splash. So yesterday or the day before we were talking about chlorhexidine or betadine. We don't want to have to wait 3 minutes sometimes for the chlorhexidine to evaporate and dry. We want to have betadine available in the OR, ready to go. And on Friday, Dr. Markley mentioned about rheostat. So we found that when we first got rheostat, we weren't aware that it had to be mixed with sterile water, or if we were aware, we didn't have sterile water in the Pyxis or Omnicell. So during the drill, someone went to get the rheostat, but didn't have anything to actually constitute it with. So now that was identified as system error, so now we have a sterile water vial in the Omnicell next to the rheostat. So I'm going to show you a video now of the postpartum hemorrhage kit before and after.
And this is our problem here. This is what I was talking about. Okay, this. There's no methogen. So we might get the right meds.
Methogen, and I'll give you the patient.
Come on. Come on. Come on. This isn't even moving my finger now. Misoprostol. Give him some oxytocin. Come on. Shoot, what's that one?
And then just hit cancel.
Okay.
Are you getting the kit?
Yeah.
There you go.
All right.
So you can see it went from over 2.5 minutes to less than half a minute, which is a long time, just a good time saving in a postpartum hemorrhage situation. So just quickly moving on to non-clinical system errors that we identified through simulation. We now have more refined communication skills. Our staff are trained to do closed loop communication. We have more awareness between the different disciplines, between the nursing care, between the anesthesia care and the obstetric care. We have specific roles for nurses. If there's an emergency, we have a nurse dedicated to help the anesthesiologist, called the above the waist nurse. We have a below the waist nurse dedicated to the obstetrician. We have a reporter, a recorder, bedside nurse, documenter. So the nurses should, in theory, it doesn't always happen, should jump into their roles, and they all know what that role, what the jobs of that role consist of. And we have the safety drills advisory. We also found that sometimes we don't have anesthesia techs, and it's useful to have a tech sometimes, or all the time. So we now cross-train the obstetric techs to be anesthesia techs. We found safety hazards in the ORs in terms of long cables being across the floor, trip hazard. So now we have identified additional outlet locations. Having to move a patient very quickly from the labour room to the OR. The hallways were jam-packed with extra gurneys, wheelchairs, things in the way that didn't need to be there. So now we're supposed to have a clear space in the hallway to transfer a patient quickly. And also now we have emergency equipment in one place rather than dotted around the labour suite. So lastly, just to acquire knowledge to systematically address system errors. So there's a 7-step pathway to prevent errors in healthcare. Now there's 7 steps, and they are on an upward trend, but each step is as significant as the next one. It's not a hierarchy. But just to highlight that communication, like I mentioned before, is fundamental, and it's a fundamental skill to have and to teach, and to educate others just the importance of clear and precise communication to prevent errors and potential patient deaths. And also reporting. So if we do have a sentinel event, it's important to report that and to debrief the whole team to find out where things went wrong and to prevent those issues recurring. So a model for reducing patient harm. So we all have individual responsibilities, but there's also system responsibilities from the organisation. So the idea is that if we do see an error, we want to be able to speak up, whether we're a medical student, whether we're a nursing student, whether we're just about to retire. If you see a medical error or potential patient hazard or staff hazard, you should have the ability in your institution to not be afraid and to speak up. And if you do have an error, to use clinical judgment, clinical skills, and for the institution to support what the clinician needs to avoid that error happening again. And just to have this culture of safety to identify the errors and then hopefully reduce them and prevent them happening over and over again. So the last slide is, I mentioned before, we have the system errors collected at every single simulation drill, and then these are then filtered by the OBSIM faculty, and we filter them into different categories in terms of who's going to deal with each issue. So we have a Labour and Delivery Safety Committee, which myself and Ed are members of. We have the L&D Management, we have the Perinatal Care Committee and the Nursing Committee. So the Safety Committee can't deal with every single error we find, so we delegate it to the most appropriate team to deal with. Now on the L&D Safety Committee, it's multidisciplinary in terms of the OB team, nursing, anesthesiologist, technician and pharmacist. And one of the key things about delegation, when you delegate things to other committees or people within the committee, is to have follow-through, follow-up. So we want to, you don't just give a task to someone and say, can you do this? We want to then have feedback from them that's actually being completed. So we meet once a month and we have a spreadsheet and we tick off things once they've been completed, because we can't always assume whoever you delegate the task to, they're actually going to do it. So we want to delegate things, but also receive confirmation that they've actually been done. So in summary, we've reviewed the definition of a system error, we've recognised benefits of simulation to identify system errors, and we've acquired knowledge to systematically address system errors if they occur. So like Neela mentioned, you're very welcome to come to Stanford and observe any of our drills, or if you want extra information from what we've both talked about, we're very happy to receive emails anytime or phone calls. Thank you.